Okay, so welcome to this next video in which we are discussing the use of the glucocorticoids to treat asthma. Okay, so we're looking currently at the mechanisms of the glucocorticoids. Okay, so what happens is glucocorticoids bind to glucocorticoid receptors in the cytoplasm of cells. This causes the glucocorticoid receptor to dissociate from these other proteins which it's usually associated with. And then what can happen is these glucocorticoid receptors, which are now loose, they can dimerize together to form a glucocorticoid receptor dimer like this. And this can either enhance the expression of genes or repress the expression of genes. So to enhance the expression of genes, it can bind to the promoter region and increase the affinity of the promoter region for binding RNA polymerase II. It can also assemble these complexes on the surface of the promoter region, okay, consisting of SRC1, which stands for the steroid receptor coactivator 1, then with CBP, Creb binding protein, and PCAF, P300 Creb binding protein associated factor, and then P300 on the top, which forms a histone acetyltransferase, which will acetylate lysine residues in histone 4, specifically the lysine at position 5 and lysine at position 16. And when you acetylate these lysines, that will cause the DNA to loosen around the histone optima, okay, and this will allow RNA polymerase to be able to come in and bind to the promoter region more easily. So that will also help to increase the expression of this downstream gene of the promoter region. In addition, glucocorticoid receptor dimers can also repress genes, and the only mechanism that we've seen for this is that they can bind to the promoter region and decrease the affinity of that promoter region for binding to the RNA pol II enzyme. Okay, and by the way, RNA polymerase II is often just denoted as RNA pol II. Okay, right, so now what we want to move on to is actually seeing which genes this is going to upregulate and downregulate, and how this is actually going to play a useful part in the treatment of asthma. Okay, right, so to start off with, let's see the inhaled glucocorticoids. So for more medium severity asthma, you use inhaled glucocorticoids rather than oral glucocorticoids. So we'll start off with how inhaled glucocorticoids are going to help with asthma. Okay, so inhaled glucocorticoids are going to be taken prophylactically, so they'll be taken at regular intervals, okay, and it will be given by an inhaler just like other drugs, okay, that are used to treat asthma. And basically, this will go into the airways and act on a bunch of cells in the airways and increase and decrease the expression of certain genes, which will help to prevent an asthmatic attack from occurring. Okay, so let me give you some examples of inhaled glucocorticoids which can be used. Okay, so some drug names now. So one of the main inhaled glucocorticoids that is used is beclometazone. Okay, so beclometazone is a glucocorticoid that can be given by inhalation for the prophylactic treatment of asthma. Another one is budesonide. Okay, budesonide. Okay, so that's another example of an inhaled glucocorticoid. Okay, another one is called fluticasone. Okay, so beclometazone, budesonide, and fluticasone. Okay, so far, fluticasone. Okay, and I've got two more. One is mometazone, and the other is cyclazomide. Okay, so mometazone and cyclazomide. Mometazone and cyclazomide. Okay, so cyclazomide. So all 5 of these drugs: beclometazone, budesonide, fluticasone, mometazone, and cyclezomide. These are all used as inhaled glucocorticoids, so they're delivered by inhalation of aerosols containing these glucocorticoids, and they're going to go into the bronchial tree, and they're going to act on cells in the wall of the bronchi. Okay, so which cells are they going to act on? Well, one of the cell types that they're going to act on is mast cells. So let's start with them going into mast cells. Okay, so the mast cell is the star of allergic asthma. Okay, these are the cells which trigger off the allergic response to the allergen. So remember, the allergen comes in, binds to the IgE molecule on the Fc epsilon R1 receptor, and this then triggers the activation of the mast cell, and the mast cell releases 4 main pro-inflammatory mediators which cause the asthmatic attack. Okay, so these glucocorticoids which we've inhaled are going to go into the bronchial tree, and some of them will find their way into mast cells. Now, what do they do within the mast cells? Well, firstly, 2 examples of what they do is that they firstly prevent the transcription of the gene that codes for tumor necrosis factor alpha. So remember, one of these pro-inflammatory mediators that mast cells released was tumor necrosis factor alpha. Now, this was the only one that was a protein that had to be synthesized from scratch in the mast cells. Okay, the others were histamine, leukotriene B4, and the cystenyl leukotrienes. Histamine is already sitting within the mast cells, remember. Okay, so I'll draw a picture of a mast cell here. So histamine is sitting within the mast cell granules, and all that you have to do is release the mast cell granules, and then the histamine is in the extracellular fluid. Okay, the other 2, the leukotriene B4 and the cystenyl leukotrienes, remember those were synthesized from arachidonic acid that was in the membrane because the cellular phospholipase A2 had broken down the phosphatidylcholine molecules in the membrane, and those are created very, very quickly. So those aren't proteins though, so they don't require transcription and then translation. So we can't block those directly by a transcription alteration, basically, which is what these glucocorticoids are going to do. However, this 4th one, tumor necrosis factor alpha, this is a protein, and upon mast cell activation, they're going to start transcribing many copies of the tumor necrosis factor alpha RNA, and then those will go on to make lots of copies of the tumor necrosis factor alpha protein. So what's going to happen is these glucocorticoid receptor dimers are going to bind to the promoter region of the TNF-alpha gene, and they're going to prevent RNA pol 2 from being able to bind to that promoter region, and therefore decrease the expression of TNF-alpha. Okay, which means that when you activate the mast cells, TNF-alpha production is going to be much lower. So if you are exposed to the allergen in your day-to-day life, then as long as you've taken your inhaled glucocorticoid this morning, these mast cells, when they're activated, will not produce much tumor necrosis factor alpha. Okay, and remember, TNF-alpha was the main driver of the late phase of the asthmatic attack. Okay, so if you don't produce that much of it, then you're not going to get the late phase. You're not going to get that recruitment of T helper 2 cells, which leads to the recruitment of eosinophils, which leads to the damage of the bronchioles. So that's nice. Okay, right. Another thing that is going to happen within these mast cells is that you're going to start producing another protein. So in the case of tumor necrosis factor alpha, the glucocorticoid receptor dimer was acting as a transcription repressor, okay? But this next protein is going to have its transcription enhanced. So the next protein is annexin A1, okay, which is also called lipocortin 1. So lipocortin 1 or annexin A1, they're both the same protein, basically. They're 2 different names for the same protein. Okay, so within these mast cells, you're going to increase the expression of annexin A1 / lipocortin 1. So you're going to start producing this new protein. Now, what does this protein do? Well, basically, it goes into the active site of cellular phospholipase A2, and it's going to inhibit the cellular phospholipase A2. So it binds to the cellular phospholipase A2, and it inhibits it. And I'm sorry, can I just take that back? I don't know that it actually goes and binds into the active site of the cellular phospholipase A2. What I know is that annexin A1 will bind to the cellular phospholipase A2 and then inhibit that enzyme. Okay, so you're going to get inhibition of the cellular phospholipase A2 enzyme by this annexin A1 or lipocortin 1. Okay, now what does that mean? Well, let's get our pictures back. Where did we have this process going on? Okay, here. When we got mast cell activation, okay, up here, when the allergen bound to the IgE, that caused calcium to go up. That caused exocytosis of the histamine granules, but it also activated the cellular phospholipase A2, which then translocated to the inner leaflet of the phospholipid bilayer and cut the bond between the second long-chain carboxylic acid and the second alcohol group of the glycerol molecule to yield lysophosphatidylcholine and arachidonic acid. And this arachidonic acid was then used to create leukotriene B4 and the cystenyl leukotrienes here. So, if you inhibit this enzyme, you don't produce any arachidonic acid. If you don't have any arachidonic acid, you don't produce any of the leukotrienes. So these mast cells are also not going to produce much leukotrienes. So, not only has the glucocorticoid had the effect that it's reduced the expression of tumor necrosis factor alpha in these activated mast cells, it's also reduced the production of leukotriene B4 and cystenyl leukotrienes. So we have taken out 3 of the 4 mediators that are released by mast cells. The only one that we haven't taken out is histamine, okay? But we have now removed the cystenyl leukotrienes, leukotriene B4, and also the TNF alpha. So, removing leukotriene B4 and the cystenyl leukotrienes, what effect is that going to have? Well, the cystenyl leukotrienes, remember, were very important in producing the bronchoconstriction, in activating the contraction of the bronchial smooth muscle cells. So if you can't produce cystenyl leukotrienes, you're going to reduce the bronchial contraction and therefore the bronchoconstriction. So that's going to reduce the level to which the airways become occluded or obstructed in an asthmatic attack. In addition, the leukotriene B4, that was involved, remember, in the recruitment of neutrophils into the lamina propria. So if you don't produce leukotriene B4, you're not going to get the same level of recruitment of neutrophils. That's going to reduce the inflammation in the lamina propria, therefore reducing the swelling that you're going to get in the lamina propria, and also helping to reduce the obstruction to the airways that you will get if you do suffer an asthmatic attack. So, that is how glucocorticoid receptors act on the mast cells, and when they're activated by these inhaled glucocorticoids, beclometazone, budesonide, fluticasone, mometazone, and ciclezamide. That's how they will work. Okay, and can I just correct that? That should be budesonide, not budesonide. Okay, budesonide. Right, so these 5 inhaled glucocorticoids will act on the mast cells and reduce their release of the pro-inflammatory mediators. However, they don't stop the release of the histamine. Okay, so you don't completely terminate all release of these other mediators as well, you just dim them down hugely. Okay, so there are other ways that these inhaled glucocorticoids will also help to prevent the asthmatic attack. Okay, so let's now discuss these other mechanisms now. So, we will now talk about their effect on the endothelial cells. So remember, the 2 key parts of the immediate phase of the asthmatic attack are that you get bronchoconstriction, contraction of the bronchial smooth muscle cells, and you also get the inflammatory response occurring in the lamina propria. Now this occurs because histamine triggers type 1 activation of the endothelial cells. Okay, now what's going to happen is that the glucocorticoid receptors being activated within the endothelial cells are also going to have effects, anti-inflammatory effects basically. Okay, so what do glucocorticoids do within endothelial cells? Well, firstly, they also lead to the production of annexin A1, just like you got in the mast cells. So you're also going to increase the expression of annexin A1, which is also known as lipocortin 1. Okay, now annexin A1 / lipocortin 1 again is going to inhibit the cellular phospholipase A2 within the endothelial cells. Okay, so what happens in type 1 activation? Why do you want lipocortin 1? Why is it useful in endothelial cells? Well, basically, remember the histamine that has been released by the mast cells is going to cause type 1 activation in these endothelial cells. And it acts by working on H1 receptors on the surface of the endothelial cells. So let me just draw some of this. Okay, so here is an endothelial cell that lines one of these little blood vessels. Okay, and you'll have H1 receptors on your surface. Okay, and histamine will come in, bind to these H1 receptors, and what it will trigger is the GQ pathway, which will lead to the release of calcium from intracellular stores. So calcium will go up in the cytoplasm. This calcium will activate cellular phospholipase A2 in exactly the same way as it activated it in the mast cells. Okay, so cellular phospholipase A2 will become activated, it will translocate to the membrane, it will break phosphatidylcholine down into lysophosphatidylcholine and arachidonic acid, and that arachidonic acid is now going to be acted upon by a different enzyme in the endothelial cells. Not 5-LOX this time. Instead, it's going to go down the cyclooxygenase route. It's going to be acted on by cyclooxygenase enzymes, and those will convert it into prostaglandin H2, and then prostaglandin H2 can be converted into prostaglandin I2. So what's going to happen is arachidonic acid will firstly be converted into prostaglandin H2, and this is done by the cyclooxygenase enzymes COX-1 and also COX-2, and prostaglandin H2 will then be converted onwards to prostacyclin, prostaglandin I2, and this is done by an enzyme known as prostacyclin synthase. Okay, so this is prostacyclin synthase. And prostacyclin has two names. It can either be called prostacyclin or it can be called prostaglandin I2. Okay, and this reaction here where you go from arachidonic acid to prostaglandin H2, I've missed out a step there. You firstly go to prostaglandin G2 and then to prostaglandin H2, and you then finally convert prostaglandin H2 to prostaglandin I2 by prostacyclin synthase. And this prostaglandin I2 will be released by these endothelial cells, and this is what then causes relaxation of the smooth muscle cells surrounding the terminal arterioles, and therefore leads to the vasodilatation of the terminal arterioles. So, if you increase annexin A1 or lipocortin 1 within these endothelial cells, you're going to inhibit that cellular phospholipase A2. Okay, so these inhibit cellular phospholipase A2. And a line with a blunt end like that means inhibits. Okay, so it inhibits this enzyme, and that means you're not going to get any arachidonic acid, because remember the cellular phospholipase A2 is the enzyme that liberated the arachidonic acid from the phosphatidylcholine. So if you've taken this enzyme out, you're not going to get any of this, so you're not going to be able to synthesize any prostaglandin H2, and therefore no prostacyclin is going to be produced. Therefore, you're not going to get vasodilatation of the terminal arterioles, so you're not going to get an increased blood flow through the lamina propria, and that's a very important part of the swelling of the lamina propria. Firstly, because increased blood flow alone is going to cause a little bit of swelling of the lamina propria, because more blood is being pumped through it. But at the same time, if you've got less blood flow to the affected area, then the effect of the other portions of type 1 activation, so for instance endothelial cell contraction is another thing that type 1 activation of endothelial cells produces in the capillaries and postcapillary venules. However, the effect of this is going to be much reduced if you haven't got the increased blood flow, because remember, the effect of endothelial cell contraction is to allow fluid from the blood to leave the blood vessels and go into the interstitial fluid. However, if you've not got a large blood supply, then you've not got much fluid to take out of the bloodstream in the first place. So increased blood flow is very important for getting this build-up of an inflammatory exudate, and if you stop it, your inflammatory exudate will be hugely decreased. So this is how you're going to reduce the build-up of the inflammatory exudate by inducing the expression of this annexin A1/lipocortin-1 in the endothelial cells of the blood vessels that are within the lamina propria. Okay, right. So that's another very important way that the glucocorticoids work within the endothelial cells. Okay, so let's look at another way that they work within endothelial cells. They also are going to increase the expression of a protein known as inhibitor of NF-kappa B. Okay, so I-kappa-B, which stands for inhibitor of the nuclear factor kappa B, NF-kappa-B here. Okay, right. Now, basically, you remember me telling you that tumor necrosis factor alpha, when it's secreted by the mast cells, which remember we're already reducing because of the glucocorticoids, but we didn't take it down to nothing. We've weakened it, okay? But the mast cells will still release some if you actually do go through an asthmatic attack whilst on these inhaled glucocorticoids, okay? So the tumor necrosis factor alpha, remember what it did? It went to endothelial cells, okay, and produced type 2 activation. And the importance of this, remember, was that it meant that the endothelial cells could then recruit a whole new repertoire of white blood cells, and specifically they started bringing out these T helper 2 cells. Okay, now, in order to generate type 2 activation, what happens is the tumor necrosis factor alpha within these endothelial cells is going to lead to the activation of the nuclear factor kappa B. Okay, now in the cytoplasm, nuclear factor kappa B in non-activated endothelial cells is usually inhibited by having a inhibitor of NF-kappa B protein bound to it. Okay, so here is the NF-kappa B, this transcription factor, which is going to activate the endothelial cells in the type 2 activatory manner. Okay, and in order for tumor necrosis factor alpha to actually achieve type 2 activation, it needs to activate this NF-kappa B basically. So it leads to downstream pathways which inactivate the inhibitor of kappa B, so that the NF-kappa B is then on its own without the inhibitor of NF-kappa B bound to it. Okay, so TNF-alpha overall is going to lead to the inactivation of the inhibitor of NF-kappa B, and then the NF-kappa B will go off, and it can then go into the nucleus, because the inhibitor of NF-kappa B was stopping the NF-kappa B from being able to go into the nucleus, and then the NF-kappa B will translocate into the nucleus, and it will trigger a change in gene expression of a whole bunch of genes, which will cause type 2 activation of the endothelial cells. Now, basically, the way that you inhibit this inhibitor of NF-kappa B is firstly you phosphorylate it, okay? So firstly you add a phosphate group onto it, which I'll show like this, and that does not inhibit it. Once you add a phosphate group on, it's still perfectly well bound to the NF-kappa B, but then the phosphorylation allows another group to be added on, okay? And what can be added on is a ubiquitin group. Now, this is far scarier for the inhibitor of NF-kappa B. So, the phosphorylation does not inhibit the inhibitor of NF-kappa B. Instead, it allows the inhibitor of NF-kappa B to then be ubiquitinated. So we're going to add on a ubiquitin group. Now, proteins which get ubiquitin added onto them are destined for destruction by the proteasome. So what happens is the whole complex of the inhibitor of NF-kappa B and the NF-kappa B transcription factor itself are going to go over to this proteasome. And what's going to happen is the inhibitor of NF-kappa B protein will gradually be fed through the proteasome and chopped into fragments. And then eventually the NF-kappa B will just break off, because gradually the protein is being destroyed more and more, and eventually the portion that the NF-kappa B is bound to will be destroyed and pulled through the proteasome. And therefore the NF-kappa B will just dissociate off, and therefore it will be free to go to the nucleus. Now, basically, in endothelial cells which have got glucocorticoids within them, okay, which are activating the glucocorticoid receptors, you are going to increase the transcription hugely of inhibitor of kappa B, or inhibitor of NF-kappa B, and there should be an of there, inhibitor of NF-kappa B, and this inhibitor of NF-kappa B therefore will be hugely expressed within the cytoplasm. So basically what this is going to lead to is it means that as soon as you destroy one inhibitor of NF-kappa B, and temporarily the NF-kappa B therefore is free within the cytoplasm of the cell, the instant it's free, another inhibitor of NF-kappa B will come along and bind to it. So basically you'll have so much inhibitor of NF-kappa B, there'll be absolutely loads spare that is just sitting in the cytoplasm with no NF-kappa B bound to it. And as soon as you release one NF-kappa B by destroying one inhibitor of NF-kappa B, then it will get bound to by another inhibitor of NF-kappa B. And that means that the NF-kappa B will never ever manage to get into the nucleus, and you won't ever get type 2 activation of the endothelial cells. So this again is going to kill that late phase of the asthmatic attack. So remember, we had the immediate phase and the late phase, and the late phase was caused by tumour necrosis factor alpha causing type 2 activation in these endothelial cells. We've seen now two methods for killing the late phase. We've seen that inhaled glucocorticoids will inhibit the production of TNF-alpha within the mast cells, but also it will act on the endothelial cells and stop the TNF-alpha from actually being able to cause type 2 activation within them by increasing the expression of this inhibitor of NF-kappa B. Now we're going to now see another way that you can inhibit the late phase of the asthmatic attack through these glucocorticoids. Okay, and this is by targeting the T helper 2 cells that come in. Okay, so remember, what happened in the late phase was that T helper 2 cells could be recruited in to the lamina propria by these type 2 activated endothelial cells, and they started producing two proteins. Let me find these. They started producing two proteins, and the two proteins were interleukin-5 and granulocyte macrophage colony stimulating factor, also known as colony stimulating factor 2. These led to eosinophil recruitment and then eosinophil activation, whereby the eosinophils released eosinophil cationic protein and major basic protein, which then led to the damage of the epithelium of the bronchi all over the place, basically. And this was then what led to the propagation of allergic asthma into non-allergic asthma. And of course, this propagation won't occur after one asthmatic attack. No, you'll have loads of allergic asthmatic attacks over the years, and you'll gradually accumulate damage to the epithelium. Okay, now, these inhaled glucocorticoids are going to go into these T helper 2 cells, okay, and they will stop the production of granulocyte macrophage colony stimulating factor and also interleukin-5, and hence stop the recruitment of eosinophils and also the activation of eosinophils, and therefore also hopefully prevent the damage to the epithelium. So interleukin-5 will go down, and also granulocyte macrophage colony stimulating factor will go down. Okay, so that is how the inhaled glucocorticoids are going to decrease the severity of an asthmatic attack. So they will be taken prophylactically. They're not just administered when you're actually having an acute asthmatic attack. Instead, people will take them prophylactically on a daily basis in order to try and prevent themselves from having an asthmatic attack. Okay, in the next video what we'll do is turn our attention to the oral glucocorticoids, which can be given in very severe asthma because they produce very severe side effects, which is why they wouldn't be given unless you really were having life-threatening asthmatic attacks.